And it's a great honor today to introduce our speaker, Dr. Adrian Gelb. I have known Adrian for probably, I don't know, a long time? Yeah, a long time. And we started together kind of in the neuroscience, neuroanesthesia section. Adrian kind of being kind of a renaissance person that seems to do well in a lot of different areas and reinvents himself every few years. Currently, Adrian is Distinguished Professor Emeritus in the Department of Anesthesia and Perioperative Care at the University of California, San Francisco. Prior to UCSF, he served as Professor and Chair of Anesthesia at Western University in Canada, and later he came to UCSF to be Vice Chair from 2004 and 2011. And like I said, Adrian's, at least initial career that I knew, was in the neurosciences, published a lot. Published things that weren't just new knowledge, but new knowledge that had an impact on how we take care of patients and our understanding. He's internationally recognized for his leadership on our field. He has served as president of 4 international organizations, including the World Federation of Societies of Anesthesiologists, which is an umbrella organization representing 142 national societies worldwide. Through this work, he works very closely with the World Health Organization. He's been a tireless advocate for expanding access to safe anesthesia care throughout the world. As a scholar, Adrian has authored more than 400 publications with over 18,000 citations. And for those of you that know what an H-index is, his H-index is 70, which is extremely high. And he's focused on neuroscience and patient safety. He has served on numerous editorial boards, delivered more than 400 invited lectures, including 18 named lectures, and has received several awards for his research, teaching, and mentorship. Above all, Adrian is a gifted communicator, and you'll enjoy the next hour listening to him. And he's really a true ambassador for patient safety. So please join me in welcoming Dr. Adrian Gelb.
Thank you very much, Dan, for that rather flattering introduction. I really do appreciate it. And I do appreciate the privilege, the honor of this lectureship. When Dan phoned me to invite me, I was actually speechless. And those of you who know me, I'm not often speechless. Because this truly is one of the highest honors, the most meaningful honors in my career. So I really do appreciate it. Hopefully the thoughts I'm going to share with you will resonate to a greater or lesser extent, but hopefully will provoke some consideration of clinical practice and patient care as you leave the room and go back to practice and consider things. My email address is here. Happy to hear from anyone with questions, comments, or even criticisms. I also want to acknowledge the ASA, whose annual meeting this is, for the opportunity to participate and the opportunity over the years to be an ASA ambassador globally, including at the WHO. I specifically want to thank successive WFSA leaderships. I've listed the past presidents there, excluding myself and our 2 excellent CEOs, Julian Gorbuth and Christine Stava, and particularly thank them for allowing me over the last 15 years to be a loud voice at the WHO on behalf of anesthesiology, whether it was within the surgery anesthesia emergency group, within the patient safety group, at the medicines group, and the human workforce group. It has been a real privilege to try and represent the specialty there. And more recently, I've been invited and actively participated with the Mexican Federation of Colleges of Anesthesia on their patient safety committee, investigating and dealing with a catastrophic event that I will include in the lecture, and helping them restructure their patient safety work. For those of you who don't know the World Federation of Societies of Anesthesiologists, it is a federation, as Dan mentioned, of 142 societies, about 151 countries, because little countries like many of the Pacific Islands band together, have a single national society, but actually representing different countries. And so we represent about 500,000 anesthesiologists around the world. I frequently get asked at events like this, how do I become a member? And the answer is, you are all members. Your national society is a member. You are a member. Your national society has paid a couple of peanuts in real terms, couple of dollars to make you a member. So volunteer, participate, and reach out. A little disclaimer, there are lots of patient safety tools and techniques out there. I've picked a few that I'm most familiar with, or that I think you may be unfamiliar with, and that I think you should get to know. It's by no means an exclusive list. It's simply to give you a flavor that there are tools out there to use. 10 years ago, in 2015, 194 countries, and I suspect that represents everybody in the room, signed off on this document. This document made access to safe emergency anesthesia and surgery a basic human right, a right that every person in this world is entitled to. For those of us in anesthesia and surgery, this was a huge step forward. But like any advance, it comes with a responsibility. This creates for us a global social responsibility to deliver on making care truly accessible. So how are we doing? If we look at it at a simple, crude metric, the unmet surgical need in 2015, when that document was signed and published, it was estimated that every year about 140 million people didn't get life-changing surgery that they needed. 10 years on, how are we doing in 2025? About 160 million people are not getting the surgery that they need. So clearly on the access front, we are not keeping pace with the growth in population, and in fact, proportionately, we are falling behind. What about in terms of the safety of care? At a global level, we're failing there too. Patients in hospital, 10% are harmed by their care. Medication errors cost millions. $40 billion from the global economy comes from dealing with medication errors. And we tend to think in anesthesia that doesn't really involve us. But every time a little misjudgment on medication doses or the wrong medication given, the patient stays in the PACU an extra hour or two, they go to the ICU in an unplanned fashion because of an anesthetic management issue, all of those add up to these billions of dollars. Hospital-acquired infections, surgical site infections, affect about 15% of patients. And we have a role in that because we are the stewards of intraoperative antibiotics. More than 1 million patients die annually from surgical complications. We are not doing a grand job on the global front. But we're in an era when many in high-income countries, and many high-income countries have said, we're not really interested in all of those poor people. So how are we doing in high-income countries? This was a study done at Imperial College in London, and they used a very useful construct originally described by Vedas Donabedian at the University of Michigan, probably about 40 or 50 years ago, looking at structure, process, and outcomes. Very appropriate to what we do as well, and the slide shows the metrics that they used. They then used 4 well-maintained global databases looking at maternal mortality, treatable mortality, death from treatment, and neonatal deaths. They created a score, averaged it, and then they reported each country and how they deviated from the average. Were they better than average, worse than average? So this is the way it looks. The United Kingdom turns out to be at the sort of equipoise point. Canada slightly above. And these are all OECD countries, so they're wealthy countries. Mexico, rock bottom on this scoring, and the United States actually not too far away in terms of national metrics on safe care. That's overall safe care. Well, you could say, we're not really interested in the overall healthcare system. We're just anesthesiologists. We're interested in what we do. So the Joint Commission, an entity we both hate and dislike, but occasionally we think maybe they do a few good things. They report every year on sentinel events. So surgically related errors remain the second highest contributor to sentinel events. And in fact, they went up 23% from 2023. And we may say, well, we're not really responsible for wrong-sided surgery or the wrong patient or those things, although we clearly do have a role. But it's interesting to note that 1/3 of those wrong site, wrong patient, wrong procedure involved regional anesthesia, our doing. And this is not unique to the United States. This is emerging in other high-income countries as well as a problem. And the main contributors, which I will dwell on at some length in the lecture, is failure to follow policies and procedures and failure to use a timeout or checklist. Now, we in anesthesia really pride ourselves on the way we have latched onto patient safety, led the way, and we like to pat ourselves on the back that the Institute of Medicine in this monograph some 25, 26 years ago, To Err is Human, called us out specifically for our initiatives in patient safety. I'm not suggesting that we don't deserve that pat on the back and the call out. I would just point out that G. Pierce, for whom this lecture is named, was an advisor to the Institute of Medicine. I suspect there was a little insider lobbying that went on. Jeff Cooper was also an advisor to this. And the figures that are in that document are here, that we've taken anesthesia-related deaths from 2 in 10,000 to 1 in 200 or 1 in 300,000. And we frequently continue to quote those numbers. What is less clear to me is the accuracy of those numbers. I suspect the 1 in 200,000 may indeed be accurate when you count all those healthy people having relatively minor peripheral limb surgeries. I think they skew this sort of statistic. But when we look at inpatient-related mortality, it's nowhere near 1 in 200,000. Publication in Anesthesiology just a couple of months ago looking at morbidity mortality in Florida, looked at a group that were inpatient but not admitted through the emergency department, and the inpatient group, so not through emergency departments, mortality 0.3%. That's 3 per 1,000. So I think we as a specialty need to take another critical look at just how well or how badly are we actually doing. But how did we come to this leadership role? The state of play back in the bad old days, so to speak, was appalling. This is from the time when I just finished my residency. This is ABC's 2020 program, which I think still exists. And look at the title, The Deep Sleep. 6,000 will die or suffer brain damage. And they estimated that it was 1,000 times more dangerous to have an anesthetic to fly in an airplane. At the same time, those of us in anesthesia were experiencing escalating malpractice suits, particularly in North America. This is from the Harvard Consortium of Hospitals, where their risk management folks noted that anesthesiologists were 3% of the faculty, but were already costing 10% of all malpractice suits. Well, what does any leadership group do when they have a problem? You appoint a committee. In this case, they actually appointed a very talented committee. You may recognize some of the faces here, including Jim Phillip, who may actually be here somewhere in the audience, John Eichhorn, Jeff Cooper, and others. And so they did a little investigating and thinking and came to the astonishing conclusion, by today's standards, that there were no standards of practice in anesthesia at all. In fact, there were no standards of practice in medicine, period. It's astonishing. The ASA, to its credit, had tried to introduce standards for obstetric care back in the mid-1970s. The membership, obviously nobody in this room, wanted no part of it. There was such outrage that the ASA was going to interfere in how I practice that they dropped the notion of standards. This group also noted that over 70% of adverse outcomes could be prevented by continuous monitoring, by the utilization of technology and the integration of technology into regular practice. A huge leap forward conceptually. They published standards for patient monitoring, the Harvard standards. This was really courageous, to say, given the ASA's experience. And they were delighted. They noted in the manuscript that there wasn't resistance, at least in Boston, and that they thought this was a good step forward. G. Pierce then utilized his position as the ASA president to initiate the founding of the APSF and other patient safety related initiatives within the ASA. Looking at it globally, you can see the huge change that took place over that period in anesthetic as the sole cause of mortality or as a major contributor to mortality. Significant improvement, which has somewhat plateaued. More disturbing is to see that in lower resource settings, as they increase access to anesthesia and surgical care, it looks like they are not seeing the same benefits that we have. And I think that likely reflects less investment in training and almost no investment from healthcare in country and from industry out of country in providing the appropriate technology. The profit margin in poorer countries is smaller. And hopefully industry will see that they have some social responsibility in helping to address this. We spawned an industry with those standards. You can see that's where we introduced standards. There was a plateau and an exponential increase in guidelines and standards. It is truly phenomenal what we in anesthesia, small group that initiated this, have done to healthcare, not just to anesthesiology care, but to healthcare in totality. And the benefits of standards and guidelines when adhered to is phenomenal, as you can see in the blue bars here, for multiple outcomes: hospital-acquired falls, morbidity, infections, length of stay, mortality. Guidelines and standards do impact practice. There is very little doubt about their ability to do that, but only if they are actually implemented. And working around standards is an everyday routine for so many of us in healthcare. This was a study looked at medication safety standards, and you can see nurses, physicians, pharmacists all work around patient safety standards. And most of us know that. We've grown insensitive to it. We talk about it. We shouldn't be doing it this way, but there's always a but on why we do that. And here's an example: vancomycin usage, the impact of not using vancomycin when it's the prescribed antibiotic, or not adhering to the timing of the antibiotic, does have an impact on surgical site infections. We don't see the consequences of what we should be doing but don't do intraoperatively, unfortunately. But what we do or don't do has consequence for patients and surgical teams. I want to share with you a very sad story that took place in Mexico, but involves patients in Mexico and the United States. And some of you may actually have looked after some of these patients for subsequent procedures without actually realizing that you were participating in a much larger catastrophic event. So here's one of the first cases. Healthy 19-year-old woman. She comes for an elective cesarean section, has an uneventful spinal, is discharged. She, baby, family, everyone really happy. Some 80 days later, nearly 3 months later, she presents with severe headache, neck stiffness, nausea and vomiting. You can all make the spot diagnosis there. She's got meningitis. She has a diagnostic lumbar puncture. She's got fungi growing in her CSF. And it's not a common fungus we get in the air. This is a soil-derived fungus. She progresses to subarachnoid hemorrhage, intracranial hemorrhage, and dies about 2 weeks after this admission. We're aware now of pretty close to 120 such cases taking place on both sides of the border. The majority of them have this 3 to 4 month delay and then present with a neurologic illness. If one looks outside the anesthesia literature, one sees these reports in the neuroradiology literature. New England Journal of Medicine reported 10 cases from Houston, all presented with neurologic features and myocardic cerebral aneurysms. We believe this is probably the largest outbreak of an anesthetic-related neuraxial adverse event from these two fungi. As the number of afflicted women grew, so too did the press reporting and the public outcry. These are some photographs from those protests calling for justice. Something needs to be done. And the response, of course, is something does get done. 7 healthcare providers went to jail, a couple of them anesthesiologists who served a year or 2 in jail. And more recently, the real culprit has been found. The CEO of one of the hospitals has now been sentenced to a recommended 24 years in jail. This is sort of the common way these things play out. You need to find somebody to blame. You blame them, you put them in jail, you dismiss them, you publicly humiliate them, and then the problem is over. Argentina is going through a similar problem. They have over 120 deaths from contaminated fentanyl that has been used. It's reached the state where the president of Argentina has jumped on the issue. His approach to this outbreak is we need to impeach or imprison the previous president of Argentina because this is all her fault. None of these actions actually address the problem and what to do about it. So one of the tools that we used in Mexico was the AxiMap. And this is a common graphical mapping approach used in industry. It hasn't been widely used in healthcare. There are some reports, investigations that have used it, but it's a very nice graphical way of looking at the entire system. So you can map out all of the component parts from government down to the individual and see all of the interrelationships. It really gets to the root of that, I would have given the vancomycin, but it arrived too late, or whatever the reason may be. You get a fairly complex picture, and you can structure this AxiMap so that it shows not only the current event, but other events, similar events, literature events, and get the whole big picture of all of the components that result in an adverse event. Now, we all like to think of ourselves as independent practitioners. You know, I decide whether I'm going to use fentanyl or sufentanil, rocuronium, vecuronium, whatever, and the dose. This is an AI-generated picture. Among my requests to Ideogram was confusion over cloth or paper caps. So AI decided no cap until a decision has been made. But the reality is we aren't quite as independent as we like to believe. We work within a hospital structure and thereby a hospital culture. We are influenced by how our colleagues behave. We are influenced by how our hospital administration behaves, not just how they talk, but how they behave. What do they actually do? And so we aren't quite as autonomous as we like to believe. Our hospitals, in turn, are subject to external policies, pressure, incentives. ASA standards, for example, APSF recommendations, the Joint Commission, CMS. Many entities provide input that influence how a hospital functions and thereby how we function and how we respond to misadventure. And one sees that playing out in this Mexican saga. Partially used vials is a problem. It's a problem in our practice, was a bigger problem in their practice. Morphine at that time, and I'm talking about just 2 years ago, was only available as a 10 milliliter vial. That was all the pharma companies provided, 10 milliliters. So you can imagine you're working at a very affluent institution, you're doing a spinal, you want to add a little opioid for post-operative analgesia. You're given 10 milliliters, you take next to nothing out of it, and there you're sitting with at least 9 milliliters of morphine. You think to yourself, well, later this afternoon, I'm going to the poorly funded public hospital. They don't have opioids for use in spinals. I'll just take it along with me and use it. I mean, that's so well-intentioned. It's so considerate. And it's within the context of a weak drug supply chain and oversight. Nobody's going to miss the fact that I've taken this 10 milliliters of morphine. Documentation, I'll just chat with the nurse, and it'll be fine. So you see egregious behavior taking place within the context of a system that facilitates and augments the desire to do good things, but with bad behavior. And so picking on the individual without fixing the system doesn't fix the problem. And this was very bluntly stated by Lucien Leap at a presidential commission on quality in healthcare. Human beings make mistakes because the systems, tasks, and processes they work in are poorly designed. And until we fix the systems, we will not fix patient safety. No matter how many lectures you attend, how enthusiastic you may be within your own practice is governed by what's around you. How do we respond to these investigations most commonly? Your root cause analysis in your hospital or within your department. This is a lovely sunburst diagram. I like that name. That looked at what are the responses, and are they weak, medium, or strong? And by and large, we opt for the weakest of responses to any adverse outcome. We have a department round. We have an M&M next month. We'll put it on the agenda. We'll ask Adrian to give a lecture on this. I have no illusions about altering anybody's practice other than my own. Or we take it a step forward, that dreaded, required 1 hour or 2 hours or 8 hours of online training. And we all know how that plays out. You skip through to the questions, or you just let it run the required hour while you answer your email. They are very, very poor ways of changing behavior. The strong ways of changing behavior, like changing technology, changing policies, changing processes, not so often. And there's almost never any follow-up. Do the hour online, you're done for a year, or for 2 years or 3 years. Doesn't matter. You answered the 2 or 3 multiple choice questions. I was horrified in doing that 8 hours of pain training. One of them had 24 questions. I mean, that was outrageous. I actually had to know something. Let's have a look at how we implement safe patient initiatives. And I'm going to use the checklist as an example. So this was the original publication on the safety checklist. 8 hospitals, 8 cities, about 6 different countries, people who'd really engaged with the process. They implemented it, and they looked at outcomes before and after. And there was nearly a 50% reduction in adverse outcomes after the implementation. This was phenomenal. Just going through a checklist, tick, 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 and it had this phenomenal outcome. Well, the Ministry of Health in the Canadian province of Ontario was really taken with this. Ontario has a population of about 12 million. And so they mandated every public hospital will use this going forward. And they didn't waste any time. They gave them about 6 months to implement it. Go to it. And we know how this plays out in our departments. I've been a department head as well. You send out this kind of email from your chairman, Dr. Friendly King, saying the checklist has done a great job. We, the hospital leadership, have decided we're going to do the same. Mouthy guy by the name of Adrian Gelb will speak to this at our department meeting next week, and we expect to see improved outcomes in 6 months. Best wishes. Sound familiar to any of you? Well, what happened in the experiment in the province of Ontario? 5 years later, so they gave it plenty of time to work in. They didn't give it a 6-month timeline. They waited 5 years to look at it. Nothing changed. Nothing. Boo. Those of us who were enthusiastic were disappointed. And then the inevitable question, who's to blame? Well, we know the answer to that. It's you. You're to blame. Well, maybe me as well. Count me in. But the reality is it's an us problem. It's not a me problem specifically. And so the questions we should ask is not who to blame, but how did it happen? Why did it happen? When did it happen? How do we prevent it from happening in the future? We're really smart. We believe in evidence-based practice, culled from good quality randomized clinical trials. We understand these things of physiology and pharmacokinetics. The question that we need to ask ourselves is, are we smart enough to know what we don't know? And what we don't know is how to implement safe practices. There's a whole science to help us called implementation science, sometimes referred to as knowledge translation. And I prefer the softer knowledge translation because I've had people who've asked me for some advice, foolishly, say, I don't want to be involved in some science project. I don't want to be part of somebody's publication. We just need our department to get this right. Implementation science is the study of how to get it right. So if we want to implement, let's call upon the experts. There are people around, many of them already in our hospitals, that go under the names of implementation scientists, implementation specialists, human factors engineering, knowledge translation specialists. I used to think human factors engineers were the sort of people who'd come and tell me my desk should be higher or lower, or I need a different kind of chair. But these are people who actually understand how to implement changes, be it in your desk, your chair, or in behavior. They're people with qualitative research experience and ability who also have skills. And one of the things one very, very quickly learns from these individuals is that behavior change is a group effort. It's multidisciplinary. There's almost nothing we do in healthcare that is me alone, on my own, with nothing else from anybody else. The anybody else could be the guy who sterilizes the laryngoscopes through to one's surgical colleagues or the pharmacy. So we always need to think about who are all of the involved people. In dealing with those people, this is my list of considerations. Gelb's 8 C's. I just love alliteration. Culture. You need to understand the culture of the group you're working with. Changing behavior in a cardiac room is different to changing behavior in the obstetric suite, or in pediatrics, or neuroradiology. They are all different cultures and slightly different ways of doing things. You need to understand the context on the ground. The inside of a cardiac room, very different from the inside of a CT scanner, neuroradiological guided intervention. How you implement in that environment will be influenced by that. You need to understand the constituency in each of those places. Talking to anesthesia, nursing, surgery, very different to talking to anesthesia, radiographers, and radiologists. You need to identify who are your champions. Who are the people who are going to lead this along in the department? It cannot just be one voice. You need a team who are going to help you do it. And you also need collaborators and enablers. These are usually people outside the department who are supportive. Chiefs of surgery, of pediatrics, of neurology, chief financial officer wants to see money saved out of this initiative. Communication style needs to be adaptable. One needs to coordinate all of these communications, and this is often tricky, there needs to be credibility in the leadership. And that means it sometimes isn't the department chair who's the best to lead on these initiatives. One of the greatest problems in conceptualizing implementation is thinking of it as a singular event. It's one event, something that one can take off a shelf, it's streamlined, and you just roll it out. That's where we've gone wrong. It's complex, it's dynamic, it's a process. It's not a static entity. It's highly variable and requires unique solutions every time. What worked at the hospital across town may not work for your department. And then, of course, there's the issue of getting the hospital on board. Hospitals, like any leadership, doesn't want something that's open-ended. You know, Adrian, that's a great idea. I think we should change this. But what do you mean you can't tell me when it'll be done? You can't predict change in behavior. You can't say it'll be done by the 30th of June. And of course, hospitals aren't willing to fund things like, can we provide people with a sandwich for dinner because the meeting's at 6 p.m., those little things. So people miss meetings. We're familiar with that in anesthesia. So many meetings, 10 a.m., or before the surgeon starts his clinic, we'll have a meeting. And so we're left out. And that is ultimately to the detriment of patients. Changing behavior is iterative. This is from a Government of Canada website on behavior change in healthcare, and just points out some of the steps involved in changing behavior and implementing patient safety. These iterative processes sometimes go by a plan, do, study, act paradigm, and I'll show you an example of that in a moment. So here's how the checklist was implemented in a hospital in Ethiopia. They brought together a multidisciplinary team, and they said, well, what are all the impediments to actually implementing this? And then after meeting with faculty in surgery, anesthesia, nursing, anybody else involved, hospital administration, they sat down and they clustered it under a couple of headings: logistics, leadership, healthcare provider, and finance. And then for each one of those, they looked for change ideas. How do we deal with each of these perceived impediments? And then they clustered them into a series of steps using a plan, do, study, act paradigm. You plan. These are the steps we're going to initiate in using this checklist. Here's how we're going to do it. Then we're going to study the outcome. Is the checklist being used appropriately? And then you decide, adopt, adapt, or abandon. So they did 6 steps to implement this checklist, as opposed to me, the department chair, saying, here's the email, do it now. They did it in a series of steps, and you can see it was spread over a year to implement this, but they went from 60% compliance to 100% compliance. Changing behavior is slow, repetitive work. Any of you who are parents, grandparents, uncles, aunts already know that you need to tell children, teenagers, more than once, pick up your clothing, turn the music down, help clear the table after dinner. It's a repetitive process. Try it this way, we try it that way. We took your pocket money away. Now we'll try rewarding you with more pocket money. There are all kinds of strategies, but it's an iterative, slow process. Here are two examples. This is introducing the Safe Brain Initiative at 4 hospitals to reduce postoperative delirium. And I draw your attention to the difference in these trajectories. The speed, the rate of change was different at each institution. All of our departments are different. This goes back to the introduction of capnography as a standard of care back in the late 80s, and this is from the Closed Claims Project, but you could see it took 6 years of reporting before capnography actually made a huge dent in outcome. Behavior change is slow. I want to share with you 2 approaches. One is a proactive process-related evaluation, and the other one is a soft tool for changing behavior. The one is failure mode and effects analysis, FMEA, as a tool, and I'm just going to give you a quick overview. If you're interested in it, we do actually have a poster tomorrow from 11 to 12 at Monitor 22. Jonathan Chechvek will be leading on that poster presentation. But this is a proactive approach to identifying risk areas that need work. Review the literature and then have a cadre of faculty, fellows, residents. I think it's a great resident teaching tool in and of itself. And then map every step in the process. So you're going to put in an obstetric epidural. Well, maybe you'd look at the chart, speak to the obstetrician, speak to the nurse, get consent from the patient, make sure your kit is available, go to the scrub sink. Every step of the way gets mapped in sequence. And then for every step, think about what would be the impact if I didn't do this? What is the likelihood of me not doing this? And what is the likelihood of this being detected that I didn't do it? So, for example, not cleaning the skin may have huge impact. Occurrence? Probably not all that common. Would it be detected? In most patients, probably not. But you can map out all of these steps. So in our exercise, we identified 38 procedural steps in putting in an epidural and 70 different ways one could screw it up. This is mapped out here. I'm not going to take you through this mapping, but you can identify high risk and critical incidents and then develop initiatives on how do we manage this? How do we prevent this from happening? In terms of changing behavior, I rather like this approach developed by Thaler and Sunstein called nudging. And nudging, which goes under the fancy heading of choice architecture, which just says, how do you give people choice? In this case, you just tell them there is another option. You don't say you can't do what you're going to do. One of the examples they use is if you want to encourage eating healthy food, you don't take away the bad stuff. You leave it there, but in front of it is the healthy stuff. If you want to get to your high carbohydrate snack, you've actually got to walk around and through the fruit, the vegetables, the healthy snacks to get there. We're not taking it away from you, but we're also giving you other options along the way. And this is a nice, simple example of using nudges. This is to encourage the monitoring of temperature, just 2 alerts. the one alert says no temperature vital sign has been detected, and all you have to do is acknowledge it. You don't have to do anything if you don't want to. And then towards the end of the case, there's no record of a temperature of 35.5 being reached. And you just click on the acknowledge. We have one for flow rates on our electronic record, for example. And you can see the rather poor use of temperature monitoring at this institution. Then they started the nudges, and there's a pretty steep incline there of buy-in. The nudges got people to actually change temperature. And then they had a period with a little computer glitch where the nudges disappeared. And so did the behavior. And then the nudges returned, and the behavior returned. So just little hints, little soft things in changing behavior. So where can you look for information about this? Well, this is clearly a self-interested call-out. We have an editorial in the BJA within the last month or so where we've covered a lot of these issues. We used these two frameworks in that editorial that you may find worthwhile looking at: the consolidated framework for implementation research and tailored implementation for chronic diseases. It applies to everything. They were commissioned to do something for chronic diseases. And then we included that Donabedian process structure outcome framework and showed where the two frameworks we had selected fit into those behavior changes. As I said at the beginning, there are other tools. This is System Engineering Initiative for Patient Safety. Builds on the same fundamental construct, presents it a little differently. Holden and Carry On have published multiple versions of SEEPs. SEEPs 1.0, SEEPs 2.0, SEEPs 101, all of them built on the same sort of processes. And if you're interested in a worked model, this was actually quite a nice worked model on medication safety, where they used SEEPs to guide how to enhance medication safety. So, summary statements. Human errors in medicine are problems of psychology and engineering. They're not problems of medicine as such. We went to medical school. Most of us are relatively clueless about the psychology and engineering requirements of changing behavior. We need to wisen up. We need to apply human factors and implementation tools to understand context. We need to bridge the gap between work as imagined and work as done. And that is absolutely crucial for those of you who develop standards. Standards are often conceived as how one would practice in an idealized healthcare system. We need to build our standards for the systems we work in. And we need to change our systems to better function the way they should. And forcing people to try and comply with standards for work as imagined versus work as done is a major contributor, in my opinion, to burnout and sourness in the specialty. You give me these tools, but you ask me to do that. Give me the right tools, and I will happily do that, and I'll do it for as many hours as you want me to do it. Give me these tools, goodbye, I'm gone. So we need context-relevant processes. We need to affect change over time. We need to be realistic, and we need to engage the people who are best able to help us and partner with us in this work. Our departments, our institutions need to demonstrate a commitment. National organizations, as I've said, need standards and guidelines that are practical, relevant, and implementable. And in that regard, I was very much taken with the recent recommendations on video laryngoscopy. That group actually has a section in those recommendations on barriers and facilitators to the use of video laryngoscopy. So a useful model. We need funders of healthcare to understand that if you make the processes and the workflow fit together, they will save lives and save money. And we need to value patient safety as a whole. It is a collective, but it is a whole of care activity. Otherwise, we will never move it forward. The notion that patient safety is something in this room, but not that room or that room, is just wrong. Hippocrates, or whoever wrote on his behalf, had it right. First, do no harm. He didn't say first do no harm in OB or pediatrics. It was first do no harm in any aspect of healthcare. We need to bring patient safety back into everything we and our hospitals do. What about you? Here's the challenge for you as a specialty. 40 years ago, we revolutionized healthcare by promoting the importance of standards and monitoring. Are we willing and able to lead in demonstrating how to effectively and sustainably implement standards into daily clinical care? That is our challenge. Our challenge isn't to make more standards. Our challenge is to figure out how to make standards and the work that they apply to consistent and integrated. Thank you.
I think we have 2 or 3 minutes for questions. If anybody has one, please go to the microphone, state your name, where you're from, and ask your question.
Thank you very much, Dr. Gelb. So I'm from Saskatoon, Saskatchewan in Canada. I'm an anesthesiologist and a student of system design and engineering. My question is regarding failure of compliance with guidelines and policies. Have you noticed any correlation between the size of the facility, whether it's a university hospital or it's a small office practice setting, and compliance with guidelines and policies? Is there anything published?
That's a really interesting question, and my short answer is no, I haven't noted anything like that, but that doesn't mean that it doesn't exist. But my impression is that there isn't a relationship. It's really about the corporate culture, and it doesn't matter whether it's a small corporation or a large corporation. The culture is what dominates. But interesting question.
Thank you.
And with that, I just want to hand Dr. Gelb a plaque here acknowledging his lectureship and his honor today. Thank you so much, Dr. Gelb, and we will take a 15-minute break and be back at 2:45.